Hello and welcome everyone to tonight's webinar, the first of two webinars on neurodiversity in childhood, brought to you by the Capital Health Network and neurodiversity experts in the ACT. Tonight's webinar focuses on childhood autism. The second webinar on the 30th of November will focus on childhood ADHD. Please check out the Capital Health Network website for a list of upcoming events. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region. And I pay my respects to their elders, past, present, and emerging. I also acknowledge and welcome any other Aboriginal and Torres Strait Islander people who may be attending today's event. Their land was and has never been ceded. I would also like to acknowledge the recent events and how they may impact the wellbeing of First Nations people in Australia. I am Dr. Leonie Harcourt, a GP advisor at the Capital Health Network. Also with me tonight are autism specialists Dr. Joanne Edwards, Sophia Hare and Katie Bryant, and of course, Kanal Mohiti for the events lead at Capital Health Network. So as with all webinars, all participants have been muted. Please address your questions in the Q&A section of the Zoom's panel, so not the chat box. And we're going to, we will have question and answers throughout the presentation. So if you think of something, type it into the Q&A box. And when there's a nice pause, we'll ask the panelists to address the questions. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share it with your networks. Regarding continuing professional development, please fill in the post-event evaluation survey so that CHN can email you a certificate of attendance after the event. And please feel free to report 1.5 hours of educational activities to your CPD home. If we go for 2 hours, you can report 2 hours of educational activities. Before we start, I just want to always highlight the Capital Health Network Health Pathways website. The login is together, and the password is for health, so all lowercase, and for health is FORHEALTH. Health Pathways are a reliable source of up-to-date clinical and referral information that is localized to the current area, and there's a lot of information on neurodiversity on the Health Pathways and about local public and private referral pathways. If you have any feedback about Health Pathways, there's a feedback tab at the bottom of every pathway. So on to our fabulous presenters, and we're very grateful for them giving up their time and speaking to us tonight. So our first presenter is Dr. Joanne Edwards. Joanne is a general paediatrician with a special interest in mental health and neurodiversity. Joanne completed medical studies at the University of Queensland and paediatric training at Martyrs Children's Hospital, Canberra Hospital, and then a fellowship in community health at the Royal Children's Hospital in Melbourne. She's completed a master's degrees in both public health and psychiatry from the University of Melbourne, and she works in private practice at the Calvary Clinics. Our second speaker tonight is Sophia Hare. Sophia is a speech pathologist and clinical leader at the Child Development Service with over 25 years of experience. Sophia currently works with children aged 0 to 6 as part of the ACT Autism Assessment Service. And our last speaker tonight is Katie Bryant. Katie is a fully qualified counsellor who specialises in neuro-affirming practices with girls and gender diverse youth. Katie has a bachelor's degree in applied social science counselling and more than 20 years experience working with children, young people and their families. Katie is the founder of Social Minds Counselling Service. This service is an innovative counselling practice that offers group work, mentoring and counselling to autistic girls and gender diverse youth. So thank you very much, and I will hand over to the presenters.
Thank you, Leonie. And thank you for inviting us to speak. I'm going to share my slides and hopefully that will work. I thought we might just start with an overview of autism, which is a topic very close to my heart and something around which I've developed a strong interest. When I was thinking about how I might put a talk together in conjunction with Sophia and Katie, I thought that there are complexities discussing autism. And one of the complexities is that I think even among the paediatricians in Canberra, there would be quite different views on the nature of autism and diagnostic thresholds, as well as useful interventions. And so I suppose that's a way of introducing the idea that this is a very personal talk. This is my assessment of where the science is at the moment and how the concept of autism has evolved over time. This little boy, and this is a stock picture, it's not a child I know, demonstrates some of the other complexities of autism.
Sorry to interrupt, Joanne.
And
We can't see your presentation. Do you want to share your screen?
am I not sharing my
You're not
screen?
sharing.
Sorry. Sorry. If we go.
Perfect. Now we can see your screen. Just needs to be on full screen.
Yeah.
Perfect. Fantastic. Thank you.
Is that right?
Yeah, that's all right.
This little boy who has autism demonstrates some of the other complexities of discussing autism, which is that this little boy, who's probably 2 or 3, looks like a lot of other little 2 or 3-year-old boys, and there might be some subtle differences in how he behaves and perhaps sees the world. But this is a condition for which there is a very wide spectrum. This little boy looks very similar to other children. He's doing something that's intelligent. He's trying to systematize his little world and put together a set of things in the way that he's interested in classifying them. And I think that adds to the complexity of diagnosis and recognition. In terms of our talk, I thought it would be useful to spend some time discussing the nature of autism as an evolving concept before moving on to the more practical elements of the talk, which are around diagnosis, and specifically Sophia's here from the Child Development Service to discuss various diagnostic pathways in Canberra, and also the additional support that the Child Development Service can provide. Autism occurs on a spectrum of, and within the framework of neurodiversity, and it is more common to have co-occurring conditions than not. And I thought it would be useful to discuss some of those before moving on to interventions, including a transition, the transition to adulthood. I'm conscious that I'm a paediatrician and I won't speak about adults with autism, although obviously the concept applies. And there is a growing number of adults with this condition or diagnosis. To start, I thought we would discuss some terms that could be applied to autism. Simon Baron-Cohen, who I have, who runs the Autism Research Unit at Cambridge University, and has been involved in autism research for about 35 years, is probably at the vanguard of our evolving understanding of what an autistic, what the, how the brain of an autistic person might be different from someone who who doesn't have autism. And he describes these characteristics of how you might understand autism. And there's a distinction made between the idea of autism as a difference as part of a neurodiversity framework with associated disabilities which create distress and difficulties for a person, as opposed to a medical model where a disorder might be diagnosed. And certainly we understand autism as part of an autism spectrum diagnosis. That's what the people are diagnosed with. And we understand autism to have some elements of a disease. And the medical framework for understanding autism is probably giving way to the neurodiverse framework. Which is a term, interestingly, that was coined by an Australian social scientist in the late 20th century to describe this variation in brain development, which the variations which could be accommodated, respected and celebrated rather than pathologized. And she makes she uses the analogy of left-handed and right-handed. One's neither better or worse than the other, but simply a state of being. And using the language, which is akin to biodiversity, that we flourish as human beings because our brains are different. And in fact, as you understand more about Tahitian figures in history, and particularly as you read about their childhoods, many of our great thinkers are likely to have had autistic features. And this has been, responsible for their extraordinary focus and dedication. The neurodiversity movement has evolved as a challenge to the medical model's interest in causation and cure, celebrating autism as an aspect of identity, recognising that it can be associated with difficulties and disability. And I suppose that's how this talk was framed, to help clarify what some of those difficulties might be, but also to celebrate, the strengths of the brain. When people discuss neurodiversity, they're often discussing this constellation of different diagnoses and conditions, which are very often co-occurring and are also dynamic. So a child with an autism diagnosis is very often affected by tics, learning disorders, difficulties with anxiety and depression. ADHD is a very common comorbid co-occurring condition. Movement disorders, including dysgraphia and developmental coordination disorder, and speech and language difficulties. Chloe Hayden, who's a local actress, who's in a very popular program, Heartbreak High, has written this book about her own journey through her teenage years, clarifying her, where her neurodivergence was clarified at last, and she was able to embrace that identity. And this is a very helpful book for some teenagers to help reframe their experience of social isolation, social difficulties, awkwardness, feeling like you don't quite fit in. If anyone has questions, and I appreciate that the talk is less medical than perhaps some of the talks that you might have experienced, please just jump in. In terms of characteristics of autism, specifically, one of the core characteristics is this systemizing interest, this interest in details, systems, patterns, rules, objects, the material world, often more than social relationships. And their interest in this objectified world is characterised by the depth of their interest rather than the breadth of their interest. So this is what allows such intense focus. Other characteristics include an inflexible thinking style, a tendency to prefer a black and white world, difficulty with the grey, particularly around social interactions. Certainly one of the core features of autism, which was drummed into us in medical school and during training, was a lack of empathy. And I think as the understanding of autism has evolved, that's become a bit more clear which part of empathy is affected. And I'm going to talk about this a little later. The sensory issues have been incorporated into the DSM-5 criteria for the first time, and they can be either a heightened experience of stimuli or a muted response to stimuli. Many co-occurring conditions, as I've said a number of times, and there are subtle, often subtle dysmorphic features and soft neurological signs that we're starting to understand a little more as we understand more about the brain of people, the differences in the brain of people who've been diagnosed with autism. In terms of communication characteristics, and this is often what's most obvious initially. A lot of children with autism will have had unusual or delayed speech and language skills. They might have a tendency for echolalia. They may use pronouns inappropriately, give vague answers, not respond to pointing or point because of a difficulty with shared attention, have unusual social gestures, occasionally speak with a monotone voice or another accent, not use inflections in their voice, which is part of the non-verbal communication, not necessarily engage in pretend play. And because of a tendency for literal understanding of communication without the backup of non-verbal communication, jokes, sarcasm, teasing can all be quite difficult to understand. And these issues tend to be associated with the perception of bullying. Behavioural characteristics are often related to both a tendency to want to understand and control the world, and so lining up cars, solitary play, playing with the details of an object rather than the whole object, being very interested in systems associated with an object rather than what it might symbolise. The other set of issues are around often unusual self-soothing behaviours, hand flapping, body rocking, spinning, close regard of objects. And these are all thought to be a way of calming. They're much more likely to occur when children are agitated. And it's a sign of intelligence that these children develop these strategies as a way of self-soothing. And despite the fact that parents and other people may find them confronting, they're often something that is a sign of intelligence and self-awareness. Inflexible thinking is a core feature of most children with autism, the ability to think outside of a binary or black and white view of the world. And that feature is transdiagnostic in that it's often associated with anorexia, obsessive compulsive traits, anxiety. And so that's why there's a lot of overlap between those disorders. And the problem in flexible thinking is social difficulties over time, as well as a tendency to some of those associated issues. This is a busy slide, and I'm not going to go through it all. It's a list of, it's in the slide pack, and it's a list of sensory difficulties. And again, just to reiterate, hypersensitive to some issues, hyposensitive. I thought it was worth just pointing out the importance of interoceptive awareness, which has become a more important and more commonly addressed issue. Interoceptive awareness is the awareness of your body's messages. And often little people with an autism diagnosis have difficulty with toileting, feeding, sleeping, sensing pain. And the current theory is that it is because there's a low interoceptive capacity, those body signals are not strong. And there's work that children can do with occupational therapists to help with increased awareness, and that's really helpful for those activities of daily living that are affected there. When we talk about a spectrum, and the current diagnosis, as I've said, is an autism spectrum disorder, it seems like a linear thing, but a better understanding would be spherical, with a whole lot of different strengths and weaknesses. And when I think about a child with autism, this is a stock picture, but you think about various categories of human endeavour, social interaction, cognitive function, and you think about, like, where would you put support in place? Where are the struggles and difficulties? Which is why no two children with autism would have similar interventions, because it's such a complex and diverse set of difficulties and obviously affected by parents and children's own goals. I'm going to keep going. In terms of our evolving understanding, I thought it would be worth just stepping back and saying, well, when do we first start talking about autistic children? What's the term mean? What's been the evolution over the 20th century? And autism is from the Greek word meaning self. And the term was first used in the context of mental health by a psychiatrist in the early 20th century to describe a feature of schizophrenia, withdrawing into the self. Interestingly, there were descriptions of children prior. This is an excerpt from some lectures given by J. Langdon Down from Down syndrome fame in 1887. And in the excerpt, he discusses children that he's seen, which he describes as idiot savants. And he describes these children as being feeble-minded. And this is certainly something that's continued into the 20th century, that there's a cognitive deficit, which is often not true. And indeed, when I did training, 70% of children on the autism spectrum, or with autism at the time, were thought to be intellectually disabled, and probably the statistic now is much closer to 20%. With better appreciation and testing. So these feeble-minded and these children may exhibit special faculties which are capable of being cultivated to a very great extent. And he goes on to describe a youth who could build exquisite model ships from drawings and carve with great skill, who yet could not understand a sentence. So again, that idea that there's this extraordinary skill, this depth of knowledge associated with communication language difficulties. classically in the 1930s and 40s, groups of children were put together as a way of trying to describe similar characteristics. And in the United States, Leo Kanner described a group of severely affected autistic children, and Hans Asperger was doing the same thing in Austria. Hans Asperger's papers weren't published until later, and he described a more subtly affected child. So Leo Kanner described children, both psychiatrists, with a powerful desire for aloneness and an obsessive insistence on persistent sameness. He came up with the term early infantile autism. Hans Asperger discussed kids with a lack of empathy, little ability to form friendships, one-sided conversations, intense absorption in a special interest and clumsy movements. He wrote a famous paper that was translated later and used as part of our better understanding of a broader range of children affected by autism in the 1970s and 80s. But back to the 1950s and 60s, where various theories about why these children might have had these disabilities were posited. And as with a lot of mental health issues at the time, there were psychological theories or psychogenic theories, one of which gained quite a lot of prominence and obviously now discredited. But the idea that these children were the result of distant cold parenting and refrigerator mother titles started to be used. Then looking at it from a more organic perspective and looking for biochemical, neurological, other causes. And I note that at the same time, ADHD was called minimal brain dysfunction. So this investment and this kind of interest in the organic nature of mental health disorders was across the board. Unfortunately, the person that was looking into these things started to look into vaccinations as a potential cause, and I'll talk a little more about that in a sec. And he also supported chelation therapy, which is the discredited, really restricted diet interventions on the basis that there was a metabolic disorder. Lorna Wing is something of a hero of the autism movement because she used those Hans Asperger papers, the translated version, to broaden the concept of autism from very severely affected children who would be kind of level 3 to the broader, more subtle, but children experiencing distress and difficulty. She herself was a psychiatrist who had an autistic child, and it was her work that contributed to the DSM-3, and I'll go through that in a minute. In the 1980s and 90s, Rain Man, the movie with Dustin Hoffman, was surprisingly influential in terms of public perception of autism because previously there were no autistic adults in the public domain. Anyone who's seen the movie knows that he was in an institution at the beginning of the movie where probably a lot of people with significant autism were placed. The other issue, the other thing that came out of Rain Man was this idea of an autistic savant, really deep interests in some areas, but difficulty with social interactions and the practical day-to-day of life. The other thing that happened in the late 20th century was the Lancet article, which associated the MMR vaccine with the onset of autism, and really caused significant difficulties both for the vaccination movement and for people on the spectrum, because there was significant stigma attached to that work. I mean, obviously it was found to be fraudulent, But one of the concerns that people had was that it consumed autism research for about 10 years. It's interesting to reflect on the DSM and how the nature and the understanding of autism has changed over time. Childhood schizophrenia was the term used to describe autistic children in the first two iterations. By 1980, which is when the work of Lorna Wing was becoming more important, there was the term autistic disorder. And then by DSM-4, there was a category of pervasive developmental disorder, which included autism as a term, Asperger's syndrome, and PDD-NOS. Unfortunately, Asperger's syndrome didn't survive into DSM-5. And we now have the term used is autism spectrum disorder with 3 levels of severity. Interestingly, we also have something called social pragmatic communication disorder, which is essentially the communication and social difficulties of autism without evidence of restricted and repetitive behaviours. The psychological framework, which Simon Baron-Cohen, who is Sacha Baron Cohen's cousin, established over that 35 years of research into autism, has been helpful in terms of really understanding what is different about an autistic brain. He's written a recent book called The Pattern Seekers, which helps explain how autism in the community as part of neurodiversity has really shaped and contributed to invention. And he describes these 2 systems in the brain, an empathizing system and a systemizing system. And it's the balance of these systems which, or the misbalance of these systems which contributes to autism. Empathy is the ability, obviously, to put yourself in someone else's shoes. And the theory is that empathy has 2 components. And while and autistic people are not thought to be great at one of those components, he divides it into cognitive empathy, which is also called theory of mind, which is an ability to understand, using your imagination and nonverbal cues, what's in the mind of someone else. And that is something that autistic people are not great at. As opposed to affective empathy, which is based on that information, what's an appropriate emotional response. And that's something that is unimpaired. And parents will often say, oh, he was really sad when this, that, or the other happened, as a reason why to demonstrate empathy, and it is empathy, but it's not the specific form of empathy that you might expect there to be difficulties around. Interestingly, the reverse, where you're good at cognitive empathy, so you're able to understand and put yourself in other people's shoes, and not able, or would have perhaps an unusual response to that knowledge, is the theory behind psychopaths. So that's one part of the balance, and the other part is this systemizing mechanism, this ability to kind of hypothesize that if this happens and that happens, then this might be the result. And he's theorized that, about 70,000 years ago, the human brain developed this capacity for what he calls if and then thinking. And this is something that's very strong in a lot of autistic people. He combines these 2 circuits. So in this graph, the empathizing circuit is on the y-axis, so the vertical axis, and the systemizing circuit's on the x-axis. And he divides, various brain types up. And this next slide, which is a summary of the 600,000 people that were contributed to this particular understanding of autism, including about 30,000 autistic people, demonstrated quite strongly the type of balance you might expect in a person with autism. In this slide, this is the extreme, the pink area, the dark pink area is the extreme systemizer. So someone who has that as a particular strength. And it's low on the empathy scale. The green dots are people who had an autism diagnosis as part of that study. And interestingly, the blue dots are male without a diagnosis of autism, and the red dots are female. And there has been theories around, obviously boys are more likely to be diagnosed with autism than girls, and that this may explain some of those things. I think a wonderful description of autism is this term takiwatanga, which is a Maori word, which was only added to the Maori language in 2017. And it translates to describe children with autism, people with autism, as in my own time and place, which is a very good description of some of the characteristics of a person with autism. And to move on to risk factors, there's a number of risk factors that have been identified, and it's thought to be strongly genetic. And certainly if you see a child with autism, there are often features of autism in their parents, sometimes diagnosed and sometimes not. And in fact, often a reason that some parents move on toward a diagnosis. As they start to understand their child's brain, it makes sense of their own human experience. There's a big genetic study which is trying to clarify genetic mutations and combinations of genetic mutations which are associated with autism. And interesting that the current research suggests that those same variations are found in people involved with STEM. And this has become slightly controversial because of concerns regarding eugenics. But that's a big ongoing study, and it's one of the reasons that a lot of autistic, as part of the workup for autism, you might do a genetic study. There's some difficulties around birth, and I'll just go through that in the next slide. Older parents and syndromic diagnoses like Fragile X. There's a thought that around in utero environment and the relative balance of insulin, testosterone, and estrogen, because there's an observation that there's an increased autism risk from mothers with PCOS and gestational diabetes, and they're testing testosterone levels in utero as a possible associated biological mechanism, and with the thinking that may explain some of the female-male differences, notwithstanding that females are enormously underdiagnosed. There have been some physiological and anatomical findings, including brain size, particularly affecting the frontal lobe, and some more microscopic findings in terms of neurons, which tend not to be pruned in the same way as a non-autistic brain. Most children with autism have lowish muscle tone, and the neurological and MRI findings are seeking to understand that association. The risk factors around birth, and this is quite a recent paper the dark blue bars or children with autism, diagnosed autism, and the grey bars are their non-autistic sibling controls. So preterm birth is a risk factor: hypoxia around birth, fetal alcohol syndrome, intracranial hemorrhage, and traumatic brain injuries, as well as infections. One of the big themes in autism is this huge increased prevalence. This is CDC data, and the Australian data, which I'll show on the next slide, is not as up to date. So in 1970, it was thought that autism affected about 1 in 10,000 people, and that's based on Canner's description of those severely affected children. As we've understood more, and for other reasons that we might discuss, the current CDC for 2023 has 1 in 36 people diagnosed with autism. So there has been a huge shift. And I suppose this is a reason why trying to understand things about autism is important. The reason, the Australian data, the most recent Australian data is from the 2015 census, and it shows a similar pattern. So these are age groups along the bottom and prevalence figures on the side. The dark blue bars are 2009 data, the middle bars are 2012, and the lighter blue bars are 2015, and there's certainly an increase. And I would think that that's been exponential, particularly for girls and adults, as we've kind of understood the more subtle presentations. The possible reasons for that hugely increased prevalence over time is associated with increased awareness and more practical support, the broadened diagnostic criteria from DSM-4 to 5, and an increased tendency for adults, particularly women, to get diagnosed, and less stigma as public figures identify as autistic, including Chloe Hayden, whose book I showed you, but Greta Thunberg has been, I think, inspirational to a lot of teenage girls. And other figures. We're going to switch over to diagnosis now. I'm just going to talk for a couple of minutes about broad issues, and then we're going to switch over to Sophia Hare to discuss the diagnostic kind of pathways in Canberra. Without boring everyone stupid, DSM-5 criteria for autism spectrum disorder across 2 domains. The first one to do with social communication deficits, and the second one to do with restricted and repetitive behaviours, but including those sensory issues which hadn't previously been part of DSM criteria. And just to compare with the DSM-4 criteria, which everyone probably remembers, there were 3 areas of deficit: social interaction, and separately communication, and separately restricted and repetitive behaviours. What's interesting about the DSM-5 criteria is they do put levels of severity, and this has become quite practically important for people, as things like NDIS may have, you're more likely to have success in achieving a package if you have a level 2, and there's some concern regarding that tendency. So level 1 are subtle issues across both domains, and they give an example. This is from the DSM. They give an example of a person who's able to speak in full sentences and engages in communication, but whose to and fro conversation with other fails, and whose attempts to make friends are odd and unsuccessful. who may have difficulties of organisation and independence forming. Level 2, the example they give is a person who speaks with simple sentences, whose interaction is limited to narrow special interests, and who has markedly odd non-verbal communication, and the evidence of restricted and repetitive behaviours, which are obvious to a casual observer and interfere with functioning. Certainly within the RACP college setting, there has been a finding that level 1 autism spectrum disorder is now very rare. Level 3 are children with few intelligible words, rarely initiating interactions, unusual approaches, responding only to very direct social interactions, with great stress at changing and extreme difficulty coping with day-to-day issues of life. And there's various diagnostic and screening tools, and that outlines some of the screening tools. And these last 3 are the diagnostic tools that are used currently. I won't spend much time. There was previously a scheme called the Helping Children with Autism scheme, which was helpful for assessment, diagnosis and treating children on the spectrum. And it's been replaced with this thing called the Complex Neurodevelopmental Disorders scheme. And the details are available at that website. Compared to the cost of a private assessment, these are very modest rebates. And I wonder whether Sophia could talk about diagnosis. I'll mute myself.
Hi everyone, so my name is Sophia here. So I'm a speech pathologist and I work at the Child Development Service, and I also manage and work in the Autism Assessment Service now. Sorry, my son's just come home, he's going to bump up the stairs. I don't have slides for you tonight. I will send some information through, but I just thought it's easier for me just to talk through a few things. So the Child Development Service is an ACT government service. We are a service for children aged 0 to 6 who are not eligible for the NDIS, but who are residents of the ACT, where there are delays in development. So that's our major work. As part of that, we also have an autism assessment team that sits within that service, and that service is for children aged 0 to 12 who are residents of the ACT, and who have a referral into our service from a paediatrician or a child psychiatrist. So to get access to our service, you do actually have to have seen, the child and the family have to have seen either a paediatrician or a child psychiatrist who has looked at that child and thought that they have seen something that may need further investigation. Look, as Jo was saying, the process for assessment is long and it's tricky and it's complicated. We use the ADOS and the ADIR, which were two of the last 3 that Jo showed us. We do autism assessments all the time. There are no 2 that I can say are ever the same. And I think, Jo said before that we treat each child individually when we see them. A diagnosis, a label, whatever you want to call it, doesn't mean that child is going to present in a certain way. It's going to give you, what we find is it gives families a way to start a conversation about how their child might be presenting. And it gives them a language to talk to others about, because I think that's one of the things that we have noticed over time is that, and there has been a real shift, and I don't know whether Jo will confirm this or not, but we used to have quite a lot of families who used to be quite upset, scared, worried about getting a diagnosis of autism, and now I think there's almost that sense of relief. I now have a way to explain. I now have have a way to, just kicking the child out, and have a way to, to talk about my child in a way that helps people to understand them and their experience of the world. So I think that's a really nice transition for the community. I think that's made it much easier for families. That's not the case for everybody, we know that, but I think it does help in some ways. So I guess I just wanted to talk about how a child may present. So I guess two of the most common presentations that we would often see. And as Jo said, what we know is that we diagnose more males than females. We are getting better at getting to the females and getting there earlier. But let's talk about, if we had parents might attend a speech pathology drop-in clinic, so they run weekly across Canberra. And they come with a 2.5-year-old male. Now, the parents would usually just report a concern is that they're not talking as much as their peers or siblings. That is usually what a parent will tell us. A drop-in clinic appointment is literally a 20-minute screen. It's us sitting there going, what can we see? What can we not see? What we might observe further is that a child is not consistently responding to their name. So bearing in mind that children aged 6 months will consistently respond to their name. So when you're seeing a 2.5-year-old that is not neurotypical and they're not responding to their name at 2.5 consistently, then we start to have questions. We start to wonder what it is. The child does not establish and use eye contact to maintain interaction. This is always one of those funny things in an autism assessment. Someone will say, oh, the child looked at you, and you're like, you're right, they did look at me, but using eye contact is more than just looking. It's about whether or not you use it to engage someone, so without speaking, and whether you use it to keep the interaction going, and whether you use it to terminate an interaction. So it's more than just they looked up at me. If the child has words, they may not be used in many different ways. So we see lots of children where the parents come in and say they've got lots and lots and lots of words, but they can't tell me that they want to drink. So that ability to use words in a meaningful and functional way, rather than actually, just labeling things. The child may appear to have some sensory behaviours that would indicate neurodiversity, such as toe walking, hand flapping, or repetitive actions with toys that appear non-functional. So, the spinning of wheels, the lining up of the toys. And while we acknowledge that lots of children, and you will see it in lots of little people, they do like to try and sort things out and control the world. The difference about a child that we would be sending on, or, saying, go see a GP to get to a paediatrician, is what happens when you try and break that? What happens when you move a car? What happens when you put things out of place? Is the reaction too big? Is the reaction really long? So toddlers can tantrum, we all acknowledge that, but are they inconsolable for 30 minutes because you put the red car next to the blue car instead of the green car? That's a different level of intensity. So it's not necessarily about what they're doing, but what the impact that has on their ability to get through and to participate in activities. So that would be a typical 2.5-year-old presentation at a speech pathology drop-in. The picture for girls is a little bit different. We would say that over the last, and we've looked at our data, so over the last 4 to 5 years, we have gotten better at picking girls earlier, but they're much harder. And it takes longer. So what we found is even the diagnosis process, so even from when we initially see them, it takes us longer to have a look at them and say, okay, now I think I'm seeing something, and get them to see a GP, to get a paediatrician, and the paediatrician often will take that little bit longer to try and, get hold of, get more information. And so we often don't see them for an assessment. I think I did one the other week who the girl was 12, so it's about where we get to. So the typical presentation that might come and see us is that the parents might attend an occupational therapy drop-in clinic. So we have speech OTs and physios with a 4-year-old girl who's recently started at preschool. The story we often hear, what families usually report, is that the child is having meltdowns when they're getting home from preschool. So making it through the day, but when they get home, that's it. We're done. We're out. The littlest thing sets us off. You know, the sauce is on the wrong side of the table. I've got the yellow cup instead of the blue cup. You know, can't take my shoes off. Whatever it is, something sets them off and it's a meltdown. And it's not just I'm tired. It's more than that. And that they appear to be having difficulty making friends at preschool. So often we hear stories in that, you know, they have a friend for a short amount of time, but then that relationship tends to break down. They move on to the next girl or the next person, and then things happen again. When we delve a little bit deeper, what we tend to find is that the child's play skills are not as varied as their neurotypical peers. So it appears like they're playing, but in fact, they're often doing the same thing. They're often doing it more often. So they're repeating an action. So they're always playing mums and bubs, but they always have to be the mother. And they're always acting out the same script. And so it looks like play until you watch it 3 or 4 times and then you realize it's a script and there's not a lot of variation in there. And if someone tries to change things, they don't manage it very well. Little girls tend to present with a special interest that's more socially acceptable. We've had quite a lot over the years who've had, you know, amazing collections of Polly Pockets or Disney characters or all of those things, which are, you know, probably slightly less socially awkward than, you know, a fascination with the planets or whatever it is that their male counterpart might have. But again, when they have those things, they use them in an unusual way. So I might have a wonderful collection of dolls, but they're always standing in exactly the same order and they don't do anything. I don't interact with them. They don't move. I don't animate them. They all just have to sit in their special spots. Interestingly enough, for girls, they tend to be described as either very shy or not aware of social boundaries at this sort of young age. So they're either, you know, in everybody's face or they're just very shy and they stand back. Again, and it's always really tricky, is they tend to have difficulty with that abstract language. So, you know, they're the kids when, you know, the teacher says it's time to pull your socks up, they look down, they're not wearing any. They tend to be verbal. The little girls, if you delve deeply, sometimes they do get some of those, like those flapping, stimming type behaviours, but they learn to mimic pretty quickly and they learn that that's not okay and they stop it. So they tend to control it very, very early. So I guess for us, when we see these children, we're looking at all of those things. We're looking for all the subtle signs. We're looking for all the, you know, the really apparent signs. We're trying to figure out, you know, what's the best pathway, how are we going to assist that family. As Jo was saying, there's been a real change in the last several years with the NDIS. And now, you know, that's the way that children get intervention and they, you know, needing an assessment and needing a diagnosis to get there. So we've seen a real shift in, you know, what that means for families and their desire for an assessment, which is fine, absolutely. But it does mean, and as I said, I manage the public waiting list for 0 to 12 in Canberra. It's not a short waiting list. We're doing better than other jurisdictions, but it's still not a short waiting list. And it can be a really stressful time. We always, you know, say to families that, you know, a diagnosis is not, you know, we absolutely believe it's helpful, but it's not the be all and end all. Any clinician who's out there working with your child should be working with what they see in front of them. Because, you know, as we know, not every child is the same. Each child is going to present differently. And just because, you know, we've done an autism assessment and given them a level 2 autism diagnosis doesn't mean that they're going to present exactly the same as the next child with an level 2 autism diagnosis. They're going to be different. I think what's really interesting, Jo was talking about, you know, this level 1 has not been, you know, used very much. And I will agree with that. We still occasionally use it. But that when we talk to families, we talk about the fact that that level can change. So, you know, when this child is at home with mum and dad and there are no demands on that child, they can actually be functioning that nice level 1. They can be verbal. They can be doing all kinds of things. When they have to go to preschool and conform and do all of those type of things, they might actually appear like a level 3 because that's a really stressful situation. There's all those children, they're touching things, they're moving things, they're, you know, there's all that noise, there's all those extra demands, and that child's system just goes, oh, I can't do this, and they can appear like a level 3. So we always talk about the fact that we have to give a level for NDIS, but acknowledge that that level will change as that child is in different circumstances, as they grow, as they go through transition. So we know that puberty is one transition. We know that heading into high school, all of those things. So I guess in terms of, you know, what to, where to, and how to, it's a complicated system. Look, I wish the system was easier. I really do. I wish there was a, you know, one way in and one way out for families, but there's just not. We will always see children at a drop-in, so speech pathology, occupational therapy, physiotherapy. We do the occasional ones who come just because they're a toe walker, and the physiotherapist says to us, "Oh, I think this one's yours." So, you know, it's about getting the family linked in, and for lots of families, it's about that first point of call. It's about having someone that they can see. It's about, if you can, referring to a paediatrician, getting them to a speech or an OT drop-in, making sure that they're linked in with someone. But sometimes it's, you know, it's just about making that starting point somewhere, so that we can, so that the family can get onto their track. Does anyone have any questions about assessment, or is that and what we're looking for?
I might put in a quick question. So the ACT Public Schools has got the school psychology system. Is that a pathway that people can follow for an assessment?
No, they do not do ASD diagnoses. No. So we are the only ACT government service that does a diagnosis. So their psychologists, lovely, great, work with a lot of them, but they are not an autism diagnostic team at this particular moment.
So if they have kind of any concerns, they would then say potentially to the parents, if they wanted to go through the public system and the child was 13, 14, is there any pathway for that? There
is no current pathway.
Okay.
Unfortunately.
Yes, that's all right. Yep.
And what we know is that, and I had some current data, and I don't know where I've put it, sorry, is the fact that what we are seeing is that there is, the numbers in children is staying steady, like the growth is steady, but as we know, the numbers in adults, particularly in females, has grown exponentially. And I work quite closely with several services in other areas, and they're seeing big jumps in that older population trying to, you know, seeking a diagnosis again, often when their child is, you know, has gone through a diagnostic process, going, oops, maybe that's me, and starting to investigate it for themselves.
If there's any other questions now's a good time to ask questions. Otherwise, we'll let Sophia and Joanne and Katie go on with the presentations. I think we're right to go on.
You want to take over, Jo?
Thanks, Sophia. That's great. I mean, while you're still, you haven't muted, have you?
I'm here.
It'd be worth just kind of saying that you can get NDIS funding without an autism diagnosis in a young child who's got evidence of global developmental delays, so delays across a couple of domains. And, you know, that's a pathway to intervention before, you know, clarity around the diagnosis might be possible. And I've seen that, you know, people are much happier to kind of wait on waiting lists where they've already accessed OT and speech and things through their NDIS package.
Yeah, and look, and that's true. And we don't, you know, there's, look, as I said, the waiting list, like if you think about, you know, if you come to a speech drop-in, you can get seen this week, that's fine. We do have a waiting list for an assessment, but at that point, someone may, depending on what's showing, we may be able to put you in the right direction and start you on a pathway to a GP, to a paediatrician. But that still can be, you know, it depends, private, public, paediatricians, there's a waiting list whichever way you're going, and then you've got to sit on my waiting list. So we will always try and link people in with services. We will do an assessment, try and get them into NDIS if we believe that that's where they should go. We do developmental assessments, so we have the ability, most of our staff are Bailey 4 trained. We have the ability to do that. We can't give a diagnosis of GDD, but we can absolutely give, you know, information to people who can make that diagnosis. So yeah, it's look, it is, and it is really important that families are linked in early. There's a lot of work done by Dr Josie Barbaro out of the Olga Tennyson Centre in La Trobe University in Melbourne about the fact that families who receive support early are more likely to stay together. They have less problem. The children do better. They get better outcomes when they hit school. So what we know is the earlier we can get families linked in, the better the outcomes are for the whole entire family.
And Sophia, the only other thing that I thought we might touch on is private assessments. So if people, need an assessment quickly for whatever reason, there are obviously a number of private psychology services in Canberra who can provide that assessment. To my understanding, there's not a multidisciplinary assessment that's available, which is, the one of the real the great things about your assessments, where you actually get a sense of their speech and communication skills, and it's more of a functional process. You get a sense of their functional capacity. But just so that kind of people are aware of that.
Yeah.
And there are
there are lots of different ways to do an assessment. So as I said, we use an ADOS and an ADIR, but we have a multidisciplinary team. So because we got a referral from a paediatrician or a psychiatrist, we often have a psychologist in the room, and we have often an occupational therapist and a speech pathologist who are doing our assessments. Sometimes there are ones that we put through to a single discipline because someone has seen them. So a speech pathologist in our service has seen them and said, I've got all of this information and therefore we don't need it. But most of the time, well, for the more complex ones, we do a multidisciplinary team. But there are services who out there who will, work with other speech pathologists who might gather that information. But a lot of them are just single clinician psychologists. You're right.
We have a question from one of the attendees. So it's, I think, Jo, this is a question for you. As a GP, can we diagnose the child with ASD, global developmental delay, which the NDIS will accept?
Look, to be fairly honest, I'm not quite sure about the answer to that question. Certainly if, there's been an assessment around global developmental delay across domains and you're feeling confident in that situation, I would often write a letter to NDIS clarifying that and supporting their application. And if GPs felt confident doing that, there wouldn't be any reason that they would need additional things. Autism is best diagnosed through those diagnostic tools, in my mind. And I would very rarely, if ever, make a diagnosis of autism myself without someone having seen a child and been through those diagnostic approaches.
It takes a while. We've got another question and then we'll continue with your talk. So the next question is, any questionnaire that the GP can use to assess the child in an appropriate time limit? I think all those questionnaires and the diagnostic tools take quite a few hours, but I'll hand it over to you, Jo.
But if I just share my screen again, back to the diagnostic and screening tools. Some of these, and Sophia, jump in if you've got a sense. The MCAT is something, and the CARS, these two assessments here up, the screening tools here up the top, could be quite often used by child and maternal health nurses. Sometimes preschools might use those tools, usually as a way of saying, look, we're picking things up. You need to go and see someone to get clarity around this diagnosis. So usually only as a screening tool.
There's also in Victoria, they're using the SAXR, which is again developed by Dr Josie Barbaro at the Olga Tennyson, and it's what they've trained all their match nurses in, and it's a screener. And it comes with an app. There's also an app that's called AS Detect that families can do themselves. That is, you look at a video and it says, my child is, does the child have pointing? It shows you what a child with who's neurotypical pointing, and it shows you a child who's not neurotypical, doing the same thing, and the family gets a score, and at the end the score says, go see your speech pathologist, occupational therapist, GP, whatever it is. So they've got the SAXR, which match nurses are trained in Victoria to use, which is a screen and does the same thing, and there's the AS Detect. But again, the ones you're talking about, Jo, are the ones that are commonly used. Yeah.
In the interest of time, we might keep moving, Leonie, unless...
Yeah, I think that's a good idea. Yep.
Okay. I wanted to talk about co-occurring conditions and some of the complexities of diagnosis. I'm going to go through these slides quite quickly, which doesn't pay the respect to these big themes in autism, but just highlights that there are these associations which are currently trying, clarity is evolving. Females are underdiagnosed with autism. And the reason for that, there's thought to be a number of reasons for that. Generally speaking, this graph demonstrates trajectories of autism with, and the pink lines girls and the blue lines boys, in terms of social communication, and the higher up on the y-axis, so the higher the curve, the more impairment there is. So boys across the spectrum, if you're diagnosed with autism, struggle more with social communication and also restricted and repetitive behaviours, which is the second plot here. And girls are much more affected over time by co-occurring conditions, so much more likely to develop mental health issues, eating disorders, and all the complications associated with those. And this is one of the things, this is the thinking behind underdiagnosis. The girls are thought to have just less of the core features, and these things are less impairing. It's very common for girls to present for the first time as teenagers when that all those social difficulties emerge, and the lack of skills around nonverbal communication become much more difficult to navigate. Yellow Ladybugs is a support network for girls with autism. Has a number of fantastic resources, including supporting your mental health and advocating in the classroom, in a document that was written with the Department of Education and Training in Victoria, freely available. Just moving on quickly, there is some evidence of overlap between genetic profiles and that empathy systemising profile for people in STEM. There isn't evidence that doctors are more likely to have autism in the current published literature. There is some evidence that healthcare workers are more likely to be the parents of children with autism. And there's an organisation established in the UK called Autistic Doctors International to support people with medical degrees in autism. And this organisation also provides excellent advice for healthcare settings around how to make healthcare settings more autism friendly. This is a graph from 2023, so it's quite recent, and it lists co-occurring conditions and their relative importance. You'll note that ADHD, so the dark green lines for ADHD, and the grey lines again are the sibling controls. The ADHD is very strongly occurring. I'm not going to talk much about ADHD tonight because we're going to do a whole talk on ADHD in a few weeks. But if you move down the list, there's significant risks for anxiety disorders, separation anxiety, other mental health issues, obsessive compulsive disorder, and there's significant psychological overlaps. Oppositional defiant disorder, and I'll talk about that in a little bit. Intellectual disability, much less than previously thought. Specific learning disorders, social communication disorders, motor delays, dyspraxia, sleep disorders, eating disorders. There is a higher risk for seizures, epilepsy, and gastrointestinal issues. Pathological demand avoidance is a emerging concept. It's quite helpful to understand and to put supports in place around specific behaviours in some autistic children who demonstrate an extreme avoidance of everyday demands, which is thought to be associated with an anxiety-driven desire for control. And there's an overlap between that concept and oppositional defiant disorder. And whole networks have been set up among parents and families and carers of people on the spectrum, particularly at the more severe end, to help with these issues. There's a very useful book for families called The Family Experience of PDA. And a lot of research, there's a thought that if DSM is rewritten, that this might comprise a subtype of autism, and is quite difficult to manage, because the more you request a child brush their teeth, for example, the more stress that's associated with that, and the much less likely that child is to brush their teeth. And that becomes a problem, obviously, around sleeping, attending school, eating, and I've seen it successfully managed through psychotherapy and occupational therapy processes where demand is and the interactions are addressed. But it is very difficult. There's a very strong overlap between anxiety and ASD. I'm not going to go through these slides in the interest of time. I'm just skipping over the ADHD slide to talk about gender diversity, and to point out that people who do not identify with the sex they are assigned at birth are 3 to 6 times more likely to be autistic than cisgender people, and that autistic symptoms or diagnosis was present in up to 20% of people with gender dysphoria, more commonly in birth-assigned females, and that there seems to be a two-way relationship, meaning that a person with gender diversity or dysphoria is more likely to be diagnosed with ASD, and vice versa. So a person with ASD is more likely to experience gender diversity or dysphoria. And Katie, who is waiting patiently, is going to talk about her approach to some of those things, which is very helpful. Disordered eating patterns are very common. The diagnoses, the disordered eating is very, very common. Sometimes children get diagnoses like pica, eating things that are not nutritive. ARFID, which is a new diagnosis, which I'll go through, and anorexia, there's a strong overlap. This is quite a nice summary of eating disorders, various eating disorders, and what parts of neurodiversity and other mental health issues that they might overlap around, and certainly anorexia associated with OCD and autism, whereas bulimia is more likely to occur in people whose main presentation is around ADHD or an affective disorder. And there's thought to be about a 30% overlap, but studies actually addressing the prevalence of this group are unclear. And I think that it's worth, the reason it's useful to discuss this overlap is the way you might treat an eating disorder where there is a strong overlap with the rigid thinking of autism, complicated by a fasted brain, could be informed by the autism literature. ARFID, which is an increasingly common diagnosis through DSM-5, is an eating disturbance manifest by persistent failure to meet appropriate nutritional and/or energy needs based on one or more of the following difficulties, which is significant weight loss, significant nutritional deficiency, a dependence on enteral feeding or oral nutritional supplements, or marked interference with psychosocial functioning, and not better explained by cultural or other issues. Over time, dietitians who see a lot of children are becoming very helpful with these issues. The concept of ARFID is this apparent lack of interest of eating or food, and I suspect that this is due to the interoceptive awareness of hunger. They're just not driven. A lot of kids just aren't driven to eat, or they get easily distracted from that feeling. There's avoidance based on sensory aspects of food. Sometimes these things aren't obvious, but texture, taste, smell can be too strong. And then there's a concern regarding aversive consequences of eating. And it's not uncommon to see a pattern where a child has vomited once 5 years ago, and the horror of that occurring again drives their food aversion. Interventions. As I said before, most people on the spectrum would have their own tailored group of interventions. The general goals would be to alleviate distress, improve adaptation, and promote wellbeing in the context of a collaborative approach. Intervention strategies may include psychoeducation, including parent education and self-awareness, various accommodations and supports, and monitoring for those co-occurring conditions. Human Rights Commission, as it pertains to people with a disability, suggests that all people with a disability should have equal access to education and employment. And there are startling statistics, particularly around the employment of autistic adults, that suggest that we are falling very short of that goal. And more work really needs to be done to promote inclusion in education and generally the community. I was talking before about the framework to support autistic people in healthcare, because obviously one of the difficulties is that accessing healthcare, particularly as you're getting older, is compromised by the unpleasantness of that situation. And this acronym SPACE has currency in terms of providing healthcare, which are neurodiverse friendly. The slides explain the acronym. This is included for completeness around current evidence regarding specific psychotherapies that may be helpful for people on the spectrum. In young children, social stories are quite important, and people like Sue Larkey and Tony Atwood, who provide a lot of parent education around autism, particularly as it pertains to schools, champion the idea of social stories, which is basically, how do I understand the day that's coming, and how can I refer to something that reminds me about that day so that it's not threatening or less threatening. So this is a social story about attending recess, and unstructured time at school is often challenging. What I can expect, what I could do if something goes wrong, in a simple visual format, to enhance kind of autonomy and confidence. Very excitingly, we've reached the point, Katie, where you might talk about specific social skills training. I will stop sharing my screen and mute.
Hang on, I'll just share. Oh, hang on. Oh. Sorry, I think I'll be ready. And I'll share my screen. Okay. Yes, my name's Katie Bryant, and I'm a counsellor who specialises with working with autistic girls and gender diverse youth. The girls I work with range from about say 11 to about 19. I do work with some younger girls as well. So yeah, Joe's asked me to come along tonight and talk about social skills and the programs we run. So I work at Social Minds Counselling and Services, and there we run the Glow Up program. So that's our social skills program for like the teenage group. Otherwise, we do have young and younger ones in there. At the moment, we've got, I think it's like more sort of 14 and 15-year-olds, but we do have younger ones and older ones that works as well. But it's kind of like a tailored approach. So we have the group work, and we have the mentoring and the counselling. So the group work, all the girls attend the groups, and the mentoring and the counselling is on a needs basis. There's 3 of us that run the group, and I have a mentor. So myself, another lady named Jo, and Tamara run the groups, and the mentoring is run by Tamara, and I do the counselling. So, it's very streamlined. We have good knowledge of all of our clients. So that's our program. Okay, I'm going to discuss the work that we do with the girls. I just wanted to have a little chat first about the importance of social skills training. Like working one-on-one with the girls is super important as well when you're doing social skills training. But we found that the group stuff is just so crucial in terms of like being able to provide that experiential experience of having a safe, inclusive space where there's other people like them, and that shared experience is just so that's where the magic happens, and there's a lot of healing in that space, and they're able to launch into skill development together. So some of the important things about social skills training is like building those positive relationships. So often girls are very astute at masking, and they've been doing that for such a long time that they tend to lose that sense of themselves. It becomes so unconscious. So they're just not really knowing that they're even masking. So it can kind of lead to like those relationships which are really toxic. So they're often just trying to fit in, and they're, very, they might get bullied or be mistreated, or, in very unsafe situations. So having social skills training really helps them to be able to learn what a positive relationship is like, and experience that through authenticity and being able to be their true selves and like find their tribe, so to speak. So yeah, having that experience with other girls really helps to encourage that, and they get to experience that, and then the hope is, you know, and that they will then be able to do that out in their social circles. We often have girls changing groups a lot and finding much more inclusive friendships where they're not having to just do all the work. Yeah, a lot of the communication skills with girls, obviously that, you know, they do the masking, but then they do struggle with a lot of complex skills around communication, like being in a group conversations and conversations with non-autistic girls. So social skills programs are really good for teaching those types of communication skills, and you know, you do things like turn taking and able to like have conversations, group discussions. Yeah, and it gives them the confidence to try that out in the world. A lot of the girls that we work with experience a lot of social isolation. So, and that's, you know, they're not feeling confident because they're not really understanding social cues and how to interpret behavior and how to manage conflict. So the masking might get them to a certain point, but then, you know, they're starting to struggle with that maintaining relationships, I guess, and keeping them for the longer term. So yeah, a lot of girls will then, because they're struggling in the groups as well, they might tend to be, you know, just prefer one friend, and that one friend might not be at school one day or like move between social groups, and then they just become really isolated, and, you know, they get lots of anxiety around this, and it perpetuates, and they become quite isolated. And yeah, so having the group and learning social skills gives them that confidence to be able to be in the group and learn those group skills and learn ways to like work with group dynamics and understand people a little bit more. And yeah, and that in turn increases their independence out in the world. Part of our program is we have the mentoring as well, so that does increase their independence. They're getting to practice that out in the community. So we're just sort of doubling up on transferring skills, because sometimes with the one-on-one work, some kids can transfer that and others can't. So that's why it's sort of on a need-to-need basis where we do the mentoring. But that, you know, is helping them to increase their independence out in the community. Often, you know, when they are isolated, they're sort of stuck at home and you know, not building those relationships to get out and do things that they might like, or feeling very anxious about it. So it also really improves their sense of their self-esteem. So it's like spending you know, time with other girls who are similar to them, with them shared experiences and the difficulties that they're having. They start to feel more accepted and more understood, which increases their self-esteem. And when they're getting more positive feedback out in their communities, you know, that starts to increase their self-esteem as well. So, you know, it's really important that they start to learn these skills for their well-being. And I think Jo was saying before that in likelihood of mental comorbid conditions that happen with girls, this really does help to give them a better sense of well-being and that connection in life and in the community. So a lot of the social skills trainings and groups, you know, they do bits with self-esteem and identity and self-awareness, which is so important for the girls. Like I said, they've been masking, and, you know, their development of their identity is delayed. So this masking becomes so unconscious, and they often, you know, that being together with other people who are similar to them, they start to like be able to think, oh, I might drop the mask and start to be myself, and that might be okay. And, you know, so it just helps them to embrace their neurodiversity and embrace their strengths, and, share their challenges together. So that's so powerful for them, having that identity awareness and the self-awareness as well. So they might be sharing experiences and learning about their unique sensory needs. Some girls might not like to be touched. Others might be really loud noises that bug them. But the really cool thing about it is that they're able to share those experiences and share those strategies they use. And once they've shared them with each other, and also they're able to advocate for themselves out in the community a bit more in their friendships, that decreases that social isolation, because they're able to say, oh, hey, I can't do this because it's really loud, but I'd like to do this with you, so they're not just stepping out completely. But yeah, so the thing that I think is the most best about the social skills training in the groups is that peer support and connection is what we've just been talking about. It. So, it's like a community. And when you're getting a sense of community, then you're getting closer to networks and supports, and, that understanding so vital. And that's that strength in, we have the same challenges and, supporting each other. And that provides a really nice platform for learning skills together. I think when you've got that really supportive environment that's very inclusive and extremely safe, that's when they can start to go into that place of exploration and really be open to learning, and beautiful things happen. And they start to think that they're not alone, and maybe they can do things, which is really lovely. That's
Katie, am I allowed to? So we're peppering questions throughout the presentation, and we've got 2 questions. I might read them out to you together. So the first one is, Katie's service able to see young female adults who've only recently been diagnosed and missed out on therapy and social skill development? And tacking onto that is, your service sounds fantastic. The attendee works in a youth clinic for disadvantaged youth. So sadly, I need to ask about costs for my clients. So they see 12 years old plus, and there's sees many clients in need of this with gender issues, eating, and likely but not confirmed ASD, and no one will help us with the formal diagnosis. So are you able to address those 2 queries?
So what was the first one, sorry?
So the first one was do you see people, young female adults who've only just been diagnosed?
Yeah, so I think the oldest female I see at the moment is about 19. So the younger adults I probably could possibly see up to 2021, but our social this glow up program is for I think the eldest is about 17, and then so the younger girls, I'm going to talk about that a bit later, how I work with them. But that's sort of the next thing is what is for that sort of young adult who might have missed out on those social skill trainings, and what's available out there for that. But we're not doing that at the moment. But I do have I will work with them a bit more one-on-one, and it's a little bit different because there's different issues going on there around, it's more like the workforce, and Joe's going to talk about that later on too. And the other question was, it's all NDIS, the same in line with the NDIS, all the pricing and stuff like that. Was that all the questions? Sorry.
So there was, I think for the disadvantaged youth who might not have a formal diagnosis, so probably don't have an NDIS package.
Oh no, yes, I definitely work with non-NDIS clients, because a lot of the girls aren't diagnosed, and I think for all the that is definitely something I will work with them. We have reduced rates for those clients because a lot of the girls aren't diagnosed, and I will work with that anyway. And then we look at working with those clients, and then they might be referring or on a waiting list for a psychologist or the paediatrician to be to other things happening. But they sometimes will go into our programs if they're happy to participate. It depends on whether they know about their diagnosis yet, or if they know about their autism and yeah, like I tend to do a lot of work with them around understanding themselves. So, and, you know, we look at different ways that they behave, or, you know, different things that they're struggling with. And, you know, we do the same sort of things while they're not having that diagnosis yet. And then, you know, I can do a lot of work with families around getting that diagnosis, like that preparatory work, I guess, and supporting them through that. So, and then at whatever point they're ready to join the program, they're quite willing to, they're allowed to, yeah. It's, but like, you know, it's sort of like sometimes if they've been masking and it's very unconscious and they have no idea they have autism, like putting them in that groups, you know, then they're not going to, it might be a bit overwhelming. So yeah, like we do, that's when the counselling comes in, and I do some work with them and we help the families. So yeah.
Sure.
Yeah.
Thanks. Okay.
Okay.
I'll let you continue.
Yeah. Okay. So the program that we run, yeah, so I said like it's like 11 to 17. We have like the girls and the gender diverse youth, and it's a bit of a tailored approach. So it's like the group work with the mentoring and the counselling. So the girls that are, I guess, younger, usually the primary school girls, or the ones that are, I guess, not really ready for that level of interpersonal stuff. I usually will work a little bit more one-on-one, but I like to go into the schools to do that. So I use the social thinking program, The We Thinkers by Michelle Garcia-Winner. I find that the schools really take that protocol on really well and start using that language, some of the schools. So it really fits with that model. And we run this in conjunction with the teachers, the support staff, and their peers where possible. So, you know, we might go out and observe the girl on the playground, see how she's socializing, you know, start teaching some of the concepts, and then, you know, bring the peers in as well. And then, you know, the staff as well. So that's been really good. But that's when they're either too young or, you know, not quite ready for that, the program. And like you might get like some of the level 3 kids that finding that that level of interpersonal stuff a bit challenging. So, you know, that's where I can sort of get in and do that individualized stuff with their actual social group in at the school, which is helpful. Okay, so the social skills program, the Glow Up program. So the group is a tailored approach to of like therapeutic support, structured learning, and opportunities to practice in real life. So we use the zones of regulation as and social thinking concepts, and like activities which promote self-awareness and coping techniques and identity and self-esteem, all that sort of stuff. So we have the group is like, it has like a check-in with the zones. That's the first part we do. And often girls can have alexithymia too. It's to have trouble recognizing their emotions. That's why the zones is such a really good tool to start to talk about feelings and emotions. And, you know, that's how they start to check in, and they tell us about how they're feeling, and, you know, get them to share a thought about their day or why they're in that zone. And this is where those shared experiences start to come in, and that sense of belonging and, you know, oh, really, that's happened to me kind of thing. And, you know, that really kind of starts to really bond the group when we do our check-ins. And, you know, they sometimes they really like the check-in. It's really sweet. So, yeah, the check-ins at the start, and then we do like a structured learning piece. Which is like I've got here. This is a social thinking concept. Ask a question, add a thought. There's also make a supportive comment. So like we use the social thinking concepts to find ways of being together. So, you know, all through the group that, you know, we'll be teaching like asking a question and adding a thought and making supportive comments. And it's just so lovely to see the girls really supporting one another and learning how to you know, really make those supportive comments around some of the really challenging things that they face. And you know, they really love adding their thoughts and getting quite good at asking questions too. So that is like a framework for like all parts of our group. And then like I really like using resources from the neurodiverse community as well. So these little things here, like the affirmation cards, which open up really beautiful conversations with the girls. The other day, one girl who's been with us for, this is just her second term, so halfway, like last term and this term, and she was like not wanting to go to school, and she didn't want to, really didn't want to have friends, and was really struggling, and she didn't even want to come to our group. And, Mum got her to come, and, she picked out this card the other day and said, "Oh, maybe I'm enough," it said. And then I was like, "Oh, okay, could you share a thought about that?" And she was like, "Well, I was thinking, I've just realized that I mask a lot, and I really don't want to do any more masking. I want to, what if I am enough?" And like, that's just such a beautiful thing for her to say, and a learning to have. And what's beautiful is the other girls in the group are hearing that as well. So it's just such a really supportive community for them. And those kind of neurodiverse tools are so good because they really hit the spot and they're really cute and quirky. So and they love them. So we make it really fun and very neuroaffirming for them. And it's so important to like have that identity piece in there. So we're not trying to teach them to be neurotypical. So yeah, and then we have like an interest-based group activity. So that is done with a group plan, which is another social thinking concept. So everybody will share their thoughts about what they'd like to do. We have a range of things, and then they have to figure out, it can get a bit tricky, but we will provide scaffolding around, or, what, just say one person has been saying they want this to do one thing, and the others have been saying they want to do the other. We might say, "Oh, it seems like this person has wanted to do that for a little while. What do you think we should do about that?" And they just come up with the most beautiful, brilliant suggestions, and, really problem solve so well and really function really well. And the, deciding the activity, and then, once we're doing those activities, that's really scaffolded by the staff as well. So you're looking at, bringing the girls in, making sure everybody's having the same amount of talk time at different times. Like sometimes, you can't, some will talk more than others, but like just making sure everybody's being heard and having a chance to, express themselves, and, really learn those conversational skills to be in a group, and, like to be able to share, and then we'll bring in some of the, "Oh, what a great question," and really just acknowledging the good stuff that they're doing and learning. And they actually really love being together. It's really nice. And then the excursions, that's their favorite. So we do that a few times throughout the term. And that's, again, about bringing those skills out into the community, teaching them how to, to navigate situations in a different environment. So we might do a lot of preparation around, what do we do if we bump into someone we know? What happens if we don't like that person? And really have some lovely group discussions about how to do that, and have some really nice fun. They love they really love going for bubble tea. So we do that a lot. Okay, so yeah, it's a tailored approach. So like the groups are really the hub, but the mentoring is, it's just something to like expand the concepts that we're teaching out into the community as well, and to consolidate the stuff that we're working on. And often the mentors there, Tamara might pick them up from school, that's when the hard stuff's happening. So it's a great time to show that support, and to help consolidate, some of the things they're working on, and to really give them that transfer of skill across the environment. And also helping them with their independence and accessing the community in a safe, age-appropriate way. And they just love it. It's fun. So it's a break for parents, but kids always come back happy. So, it's just that time where they can all just go, "Oh, that's, a really safe, fun way to socialize and reduce that social isolation." And, that relationship between the mentor, we found, is just so key. A lot of, like we said, with the masking and mimicking of behaviors, and it's just having that grounded person, helping tune them back into their goals and what's important to them and the way that they want to be in the world, just helping them to check back in, which is so helpful. It's very been such an important thing, part of the strategy. And also, so things that might be like mentoring, sort of like about going out into community and accessing the community, and the skills that they're learning. Counselling can kind of, because, there's obviously other deeper issues that might come up that is needed for counselling, and, it might be a bit heavy for the mentoring and, not appropriate to bring up in the group. So those, and, if it's substantial enough, then we look at maybe doing the counselling, and they can do the group mentoring counselling, or the group and counselling, or, whatever it is they need. So we wouldn't just stop the mentoring because they need the counselling. And Tamara and I work very closely and know what issues we're working on, and really work really closely to sort of really solidify that stuff as well. And then we might talk about like more specific social situations like bullying. So, we might need to unpack that a little bit more, might need to have like a parent session, talking about advocating to the school, all that sort of stuff, doing a little bit more visuals and social scripts, and helping them, the social stories, helping them really understand what's happening, and then empowering them to make, to make changes. So like if there's more mental health issues or change, or just a more emotional support that's needed. The counselling's a neuroaffirming practice, and it's trauma informed. So there's like these little things up here, like so a lot of the time, some of the counselling stuff is just can go against a neurodiverse person and the way that they, the needs that they have. So a lot of the time, I've spent adapting my practice to help the girls be able to have the support they need. So we've got like these little card things here, and then so it's very visual, yeah. So, and it's like these are very neuroaffirming because there's lots of things like that are so relevant, and I find that they're really good at getting to the things that that they need to talk about, but in a way that's very stepped out and staged, and like they can sort of, the way that their brain will be able to process, and they often have a lot more insights that way. This is like a sensory type thing. So I find when, and a lot, we've done this in the group as well, a lot of the time when you're talking to girls, when they're if they're actually engaged in sort of a sensory type activity, then there's more flow and there's more capacity to talk about things, and it also brings in like that sort of anxiety type stuff. And then this lady does some really great things, and this is like a worry pond thing, but it helps. It's a little bit like a flow chart where it just stages out with, if I feel like this way, yes, and I feel like that way, no, and it helps them to like really work through some of the worries that they might have, and then the tools that they have, the beautiful things, then they can take that home with them. So a lot, everything that we do is like really neuroaffirming, and working in with the mentoring and the group as well. So it's kind of like it's supporting it. It's of course the girls in the group are going to go through struggles, so then we're giving them that support as well, so as much as we can with the mentoring and the counselling. So yeah, that's it. And I just wanted to tell you a couple of things that the girls have said with the feedback. I don't know if I'm going over, but and it just sort of really speaks to what they find is really important to them and what helps them. They say like the inclusivity in the group is amazing. It always feels like everyone is involved and every voice is heard. And I really like the activities we do. And the best thing is there is no judgment and everyone understands me. So it's kind of like having that beautiful space where they feel understood and heard, and there's inclusion. And then you've got like a family member saying, we are so proud of her and have noticed since starting the Go Out program, she's becoming more confident, less anxious, which has helped her at school be more happier and at home. Overall, she's happier and less anxious. So, there is that knock-on effect of like it helping anxiety and helping, their well-being, and helping them deal with some of those other issues that are presenting, but it's, what the girls are saying they love is having their voice heard and feeling like they've got that community. So, but anyway, thank you. And yeah, that's the service.
That's great. Thank you very much. An attendee wanted to know if any of those tools are readily available for purchasing.
Yeah, online you can, and that's all the links there actually. So I've put them all there, the polyvagal team. One of them's from the UK. But yeah, so that sugar and sloth stuff is from the UK. It come really quickly actually. And there's heaps of really cool stuff on there for the girls. And yeah, the little potion one is here in Australia. All the zones of social thinking and that is very useful. That's all. You can purchase that online too.
And we send out the the resources to attendees after the event, so they should be on the resources. Thank you. Okay, back to Joe.
How do I do this? Take it off.
Yeah, stop sharing.
Oh, stop sharing.
Yeah. Thanks. Thank you. Thanks, Katie.
Thank you.
I'm conscious of time and everyone's patience. Katie, that was fantastic. And one of the reasons I wanted to have Katie come and talk is because I get feedback about how helpful and how wonderful that experience of neuroaffirming and self-awareness growing and social support, how helpful that is for young people with autism. Now, I think that is my slide back? Yep.
Yeah, we've got your slides.
Right.
Yep.
And I'll only be another 5 minutes or so, but unusually we're putting medications right at the back of this presentation because there's no evidence that there's a medication to treat autism. There's some, and in fact pretty limited evidence that medications can be helpful for the co-occurring conditions. And often those co-occurring conditions are managed as for a neurotypical child because the research is so sparse. One of the characteristics of little people on the spectrum is they're very sensitive to psychotropic medications. The medication that we all worry about and is used under a PBS approval is risperidone, and it's used for severe behavioural challenges associated with often irritability and aggression, and it can be very helpful for that, and obviously limited by its side effects. In America, there's FDA approval for risperidone and aripiprazole, which doesn't have PBS subsidy here, but can be used as a backup depending on a response to risperidone. It is thought to have less metabolic side effects in children. I'm not going to say much more about medications. The mental health and well-being of adults with autism is pretty poor and eye-opening. There's quite alarming statistics around suicidal ideation and very poor mental health. And the unemployment statistics in the UK are that about 85% of autistic adults are unemployed. In Australia, again, this is 2017 data, and there has been a shift in severity, so this might look different. But 3/4 of adults with autism were on the DSP, and various other and a very small proportion of adults with an autism spectrum disorder in 2017 were in paid employment. And people rightly feel that this is a human rights violation because of all the advantages of being able to be employed in terms of autonomy and self-care and meeting people and opportunities for growth and development. However, there is a movement and employment programs and school leavers programs which can support autistic people in the workplace. This document, which was written by La Trobe in combination with DXC, one of the IT companies, is basically a footprint for how you might support a neurodiverse workforce, and various programs have been set up across various IT companies, defence forces, government departments and banks, using this kind of platform, which is obviously a step in the right direction and very helpful. Just to finish with some NDIS data from 2022, 34% of the participants on NDIS have autism as their primary diagnosis, and 64% of those people are under 15. So these statistics will change, obviously, as the cohort who are now children move through the system. 90% of participants with autism are under 25 currently, and 71% of participants with autism are male, and that is reflective of the male-female balance now. They're all the slides that I was going to go through. I'm happy to have questions, and Sophia and Katie are obviously still present and would be, I'm sure, happy to answer questions as well.
Oh, that was fantastic. I thought it'd be interesting to see what the international statistics are for the DSM level 1 diagnosis, given DSM is an international diagnostic kind of framework. So you were saying in Australia that there's very few level 1s. That's a strange phenomenon, given
It's increasingly rare, I think.
Yeah, and that's all NDIS driven, I imagine. Yeah. If you have any questions, now's your last moment. Otherwise, we'll wrap it up. That was just great. Thank you very much for Joanne, Sophia and Katie for your such excellent presentations. And we've had a lot of participant engagement with it. So yes, the next neurodiversity webinar will be on the 30th of November, and that'll be on ADHD. So make sure you attend that. That will also be very interesting as well. And we will be sending out the slides to attendees, and we'll be putting the presentation up on the YouTube Capital Health Network YouTube page as well. So if you've missed anything, or if you want to catch up on anything, it's there as well. With the CPD, fill out your evaluation survey and send it back to CHN. You should be able to actually report 2 hours of educational activities to your CPD home. I think that's it. Yeah, that's it. But thank you very, very much to our presenters. You put so much effort into it, and we've all really appreciated you sharing your knowledge with us tonight. Thank you. Good night.
It's a pleasure, Leonie.
Thanks.
Bye.
Thank you.